So today also we'll discuss another topic, which is doesn't or probably similar or even more difficult than neovascular glaucoma, which is the uveitic glaucoma. Uveitic glaucoma is a relatively common complication of uveitis. It's a relatively common complication of uveitis, and historically, the uh, the first definitely yes, complication, and the management is difficult as in glaucoma, and despite of the availability of the new medication, yes, the picture has changed when you compare ourselves to the past few decades. The medication is changed, improved, whether for the glaucoma or for the underlying pathology, uveitis. But still, this management is still not easy. So historically, the association between glaucoma and uveitis credited to Beer in the 19th century being the first to describe the association of the both conditions. So has been recognized since 18 or 19th century. So, what is the prevalence of the disease? This prevalence probably since a long time or so, but still the reported series now with the improvement of medication and improvement of uh, حتى awareness of patient, awareness of the importance, how do we treat the disease itself, the underlying pathology, has reduced the prevalence of the disease being 10 to 20 probably in some series probably more than that. But nowadays, in general, the prevalence is much less than this figure because of, as I said, the improvement of the treatment as well, or recognition, as well the improvement that we need to take care of the underlying pathology, then to treat the glaucoma or the complication of the underlying pathology. So it is about 10 to 20%, and has been the incidence increases with chronicity of the disease. As you see here, for example, in the first year or 6 years or so, first year is about 6 or 7%, rise up to almost 23% after 10 years. And many reports regarding whether this chronicity or the incidence is the similar among all different types of uveitis. Neri and his group, uh, 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 they studied about 390 something patients, and they found that this is an American population. They found that uh, the incidence is equal among or regardless of the type of uveitis. However, other nations and other studies from different parts of the world, like in Japanese, they found that the certain types uh, associated with much more prevalence or incidence of the glaucoma, like in Japanese group, the large group, 1,000, more than 1,000 patients with uveitis, they found that sarcoidosis, about 34% of them, of the glaucoma cases that they, 44 eyes of the cases that or they develop the glaucoma, most common in sarcoidosis and in herpetic anterior uveitis. So, yes, not the topographic, the underlying pathology, the type of the disease is not similar the incidence of glaucoma and all types of uveitis. Similarly, in our population here, a nice report by Rubai uh, 10 years ago or so, we found that also the glaucoma incidence or prevalence is much more with certain types like the sorry, like the HLA B27 positive uveitis. This is the highest incidence in our series, which is again it's a large series, 1,000 or more 1,000 patients, and again juvenile idiopathic arthritis. This is another condition that the association of glaucoma is much more than the other entities. So yes, it is different. The incidence and prevalence of the disease differ from type of uveitis or based on the type of uveitis and probably the what you call it nations and so on, or the uh, such a thing. What you call nation. I mean ethnic differences and so on. So what are the risk factors that lead to development of secondary glaucoma or elevation of the intraocular pressure? This is very important slide. Well, yeah, when you are dealing with a patient with uveitis, you need to know or to have an idea about all the patient as a complete. His age, for example, and we know that the disease is the disease of middle and early or young and middle age of patient. Rarely you find it in an old age group, but when it occurs in old age group, uh, uh, we know in old age group, this is physiologic normal. The function of the trabecular meshwork declines with aging. Its function and competency when you are 70 years or 60 years, not as when you are 30 or 40 years. Similarly, also the aqueous humor production is less or getting less and less with aging. So there is a matter of balance between the production and outflow facility or drainage goes with age. Yes, both of them decreases, but there is some sort of balance. So anything that or any insult that or can lead to unmask the this imbalance. So, for example, myelofibrosis can lead to secondary elevation of the ventricular pressure or secondary glaucoma in a patient if it's happened in a patient in 60 or 70 years. If this type of uveitis or degree of uveitis or severity of uveitis happened or occurred in a young man or a young patient or a young person will not cause any elevation of the pressure. The capacity or the quality of function in trabecular meshwork in young people is much better than in old people. Yeah, it's normal. Everything. Hatta if you have a car, you want to go old car to go and something up, يعني طلعة كده. Probably the old car or it will not be able. The young car will go easily. So yes, there is a change in the function of production and drainage in all the age group, and this is established, well known. So anything that can change one of these will lead to or break the balance between the two systems or organs. Chronicity, again, chronicity is a major risk factor that the longer, as we said, and we have seen in the first or second slide, that with the chronicity, the incidence of prevalence of the disease increases. After 1 year, 6% or so, and when after 10 years, goes up to 23 or 22 or whatever. So, and this is indicate what? Indicate the cumulative effect of inflammatory condition on the trabecular meshwork. It has a cumulative effect, chronicity. It's not an acute stage or acute episode and gone also and the angle correct itself. No, this is a chronic insult to the trabecular meshwork. Yes, there is an insult for the ciliary body, but the imbalance is in favor that the function is much less than the production. And this is not only that, but also as we see here, the corticosteroid use. It's, it is the uh, primary modality of treatment in non-infectious uveitis. So we need to use these steroids. And the steroid, we know in normal population, when they started challenging the tropical meshwork, they found a response. It was a short, long time ago. It was a short challenging of normal eyes with the steroid. They have seen that there are some eyes that respond very quickly, very high, more than 15 millimeter of mercury in a short time, 4 to 6 weeks. And the majority, they are called moderate responder. We'll see it properly later on that about the pressure elevation is less than 15, and there are high responder, smaller. What are they? So moderate responder is about, I think we'll see it, 33. This is more called moderate. Well, I will not discuss now moderate uveitic. Like a high responder, they are up to 5 or 6%. These eyes, when you challenge them with steroid a short period, you will see an elevation of the intraocular pressure, as we'll see later, within a short time. Severity of the disease also. The severity of the disease as is a risk factor for the development of the condition of the glaucoma, I mean. So, and they found that some signs of severity, like when you have a patient with posterior synechiapresence of posterior synechiae indicate that the disease or the inflammation is so severe. So they found that in a series that they found with juvenile idiopathic arthritis, they found that those with posterior uveitis, the incidence of the glaucoma was 45% compared to those without posterior synechiae. So posterior synechiae indicating or indication or a point that indicating the severity of the disease. So severity of the disease is a major cause or a major factor in the development of the glaucoma. So again, HLA-B27 positive uveitis found to be also very strong inflammation, and it has the development of a glaucoma in these eyes with HLA-B27 positive uveitis is four times more than the HLA-B27 negative uveitis. So clear. So these are very important risk factors. When you have a patient, such a patient with this criteria, you need to expect that this pressure will, or the development of glaucoma, so I have to be aware about that. This is very important slide. Good. So how the pathogenesis of the glaucoma development, how it occurs, why, or what are the mechanisms involved in this situation? There are, as you see here, there are biochemical and cellular changes in aqueous composition and its dynamics, we'll see later. And there is a direct involvement of the trabecular meshwork as targeted as a primary tissue or primary target for the inflammatory process. And there are certain types of uveitis that responsible for this. Again, as we mentioned earlier, the corticosteroids is, of course, it's a therapy, but it has an effect on already insulted trabecular meshwork. We know its effect in normal subjects, so its effect on an already insulted trabecular meshwork will be more. So corticosteroid therapy being a treatment, but also it can share or usually shares in the development of glaucoma. Then these mechanisms or the ABC. These are happening in a macroscopic way. Yeah. So we call it a macroscopic changes on these things that lead to open angle glaucoma, which is the most common type of uveitic glaucoma. Most of that time is open angle. So these changes usually associated with open angle type of uveitic glaucoma. Then there is a morphological changes in the anterior chamber angle that we see in the first picture. I show you two pictures, that one with broad and peripheral anterior synechiae, that is, both of them are my patient long time. The left one with the broad synechiae was when I was second year, and the other one probably 15, 16, or 20 years ago. So these morphological changes lead to elevation of the pressure, and we need to know how to manage these things. And the management is different according to the type of glaucoma you are dealing with. So we need, as we'll see later, we need to know exactly what's the underlying pathology, a cause, and a type or mechanism of the development of a glaucoma in order to deal with the glaucoma and reach a good outcome. Good. Pathogens. So what are the biochemical and cellular changes in aqueous humor? What the aqueous humor is not as a normal aqueous humor. There are a lot of changes in the aqueous humor. Like what? Like proteins. In patient with uveitis, the concentration of proteins, as we'll see, differ from its concentration in normal subjects. Inflammatory cells, there are inflammatory cells. There's also inflammatory mediators, cytokines, and due to this inflammatory cell. So in protein, usually in normal aqueous humor, it consists about 1%. والله انا ما اقدر اسلم عليك وحشني لكن بنتظر لما نخلص. اي نعم. So the 1% is about its concentration in the aqueous in the serum. So in uveitic patient with severe inflammation, it may reach to the level of its concentration in the serum itself. So this is when we see a plasmoid aqueous. You call it plasmoid aqueous there where the cells doesn't move in the aqueous humor. So stagnation of the movement of elements of the aqueous content. And this is why there is increase in production of aqueous of protein in the aqueous humor in inflammatory conditions because the permeability is increased. There is severe increment in the permeability of the and breakdown of the blood aqueous barrier, so pouring the proteins in the anterior chamber. In addition to that, in severe cases, as we mentioned, it can be resemble aqueous humor serum. So the presence of such an concentration persists lead to direct and indirect uh, uh, causes of elevation of the pressure. Indirect, it works as a mud. Is yeah, difficult movement of this abnormal aqueous content through the trabecular meshwork. So in addition to that, also presence of high protein contents in the anterior chamber will facilitate the formation of posterior synechiae as well as peripheral anterior synechiae. It's not necessarily peripheral anterior synechiae occur as secondary to posterior synechiae, but in narrow eyes, like in our population here with high percentage of our population have a narrow angle, not necessarily to be a narrow angle glaucoma. So presence of such huge amount of protein can precipitate to formation of peripheral anterior synechiae without posterior synechiae. But posterior synechiae, as we mentioned, and peripheral anterior synechiae is a sign of severity of the disease. You can interrupt me anytime, please. So again, in biochemical changes and so on, inflammatory cells we mentioned. This is one of the first, or the picture that I put in the first slide. You see there is something here. ما هو موجود ليش؟ ما أنا فكرت ورا ما يشتغل الماوس هنا. طيب. There's something in the angle here. This is an open angle. But you see there are these things. What are these? These are inflammatory aggregates in the anterior chamber angle. These aggregates or inflammatory nodules lead to elevation of the pressure in different mechanisms. First, directly lead to infiltrating the Suez Canal and plugging Suez Canal because of this heavy infiltration of the inflammatory cells. Second, these cells release what? Release release inflammatory mediators altering the cell size, function, and extracellular matrix. So not only mechanical blockage, but also the release of these mediators has a deleterious effect on the function of the trabecular meshwork cells. This will lead to elevation of the intraocular pressure. If this is not treated properly and if the angle is really affected much, then again, the inflammatory mediators, cytotoxic, cytokines, and so on. This is the area of Prof. Blanchard and probably Prof. Khalid Abomero. So there is an cytokines called interleukin-1. But this is doesn't work. Yeah. No, interleukin-1. Anyone can show me how do I? Abdallah قيم تعالى شوف. شوفوا بوك مزنوق مره واحده محتار. قال لك انا بشوف شلون احرك So this interleukin-1 activates certain enzymes in the eye that lead to such as matrix metalloproteinases. No, I need to have the the شو اسمه يسمونه الفاره هذه تحركها تشوفها هنا. ليزر ما يشتغل. يبغى المره دي خربت. انا قاعد اجرب. طيب so ايوه شكرا حبيبي الله يعينك خش ولا مش ايوه لا بس ثانك يو فيري ماتش طيب شكرا الله يحفظك ف this interleukin 1 activates certain enzymes that related to the matrix or called matrix metalloproteinases. These lead to degradation. This is very important. Degradation of extracellular matrix. This what will cause. This will increase. This will affect the uveal scleral outflow, causing increasing. Yeah, it leads to about four-fourths of its usual function in draining the aqueous humor from that route. So this will lead to the decrease of the pressure. This decrease of the pressure due to this release of the effect of interleukin 1 on these certain enzymes, matrix metalloproteinases, not only the reason that lead to hypotony also in active uveitis, but also in active uveitis, we know that there is a reduction of aqueous humor production, reduction of aqueous humor production of the ciliary body. So both of them, they will lead to less aqueous humor. This less aqueous humor, we know that الترابيكال مشوار depends in its nutrition mainly on the aqueous humor. So, and we need to make this trabecular cells alive and healthy. It needs normal aqueous humor to be perfused not less than 1 microliter per minute. In such situation, the aqueous humor production is less. The shifting of aqueous humor drainage shifted to the drainage is shifted to the uveitic flow, so will be deprived from its nutrition. So this effect of cytokines and so on the trabecular meshwork also lead to direct cytotoxic effect and stimulate its migration. So once we start to treat the condition, this of course lead to decrease of the movement of the aqueous in the conventional route, or trabecular meshwork. And then this will lead when the eye treated and the uveous curative flow back to its normal or even subnormal because the eye is affected, as well as the ciliary body having a much better production when you treated the condition, although it might not go to its normal productions level. But again, when the aqueous shifted to this is very important, and if you are interested in understanding the pathogenesis of the mechanism of a problem in secondary glaucoma related to or microscopic and open angle uveitic glaucoma. So when the aqueous shifted to the main conventional route, the trabecular meshwork, we'll find the trabecular meshwork is not working, has been insulted by either the protein itself mechanically or by the cytotoxic materials or by depriving it from its nutrition. Is it clear or not clear? Fine. I will. So, yeah. So, okay. It's not a mere shame. This is the time to ask questions or to show that you didn't understand. Anyhow. So, this is one thing. Then we come to the direct involvement. In certain conditions, the trabecular meshwork, its affection is not as a consequence of an inflammatory insult going somewhere. Here, the trabecular meshwork is affected directly by the inflammation. There are certain types of uveitis that directly involving also, in addition to the anterior segment, involving the trabecular meshwork also, like like Boston or cytomegalovirus and Fox uveitis, herpetic keratouveitis. These are three. The elevation of the pressure is always with this type of inflammations, and this is because of the direct involvement of the underlying pathology to the trabecular meshwork itself. And then we come to effect of corticosteroid. This is what we were saying. We mentioned that about 32 or 33 of normal population, we consider moderate elevation, that's elevation of the pressure or responder elevation of pressure about from 5 or 6 to 15 millimeter of mercury. If the eye, normal eye, challenge it with the corticosteroid, and about, I think, five or so, 4 to 6 high responder, the elevation is more than 15 millimeter of mercury. This normal eyes, I mean, healthy subjects. So imagine if such a thing, this is for short time also, weeks. So when I teach my resident and my student, I said, yes, this is when we challenge the normal trabecular work with steroids for a short time, month, 2, 3. But in such disease, uveitis, you need a long term treatment with this corticosteroid. So definitely, they will the steroid usage will affect the trabecular meshwork function, as we'll see later through their mechanism. So yes, this is the situation. Just a small that we need to know that in normal or in primary optic glaucoma, usually these consider this is nothing related to our subject. That one of the primary glaucoma as well as children. They are very, 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 I put it here just to remind, to mention that this point of information. They are considered to be high responders. 50% of people with primary glaucoma or their relatives even, they are considered high responders. So you keep an eye on these people. So patient with primary glaucoma, 50% found to be high responder. So keep an eye on their relatives. Maybe they have such a character also. Children also, sometimes in a matter of hours, you can see the pressure elevation. So keep this in mind when you're treating a child with steroids for whatever, I mean, lotion, allergy, whatever. So keep this in mind. How does it affect elevate the pressure, increase the pressure? As I told you, reduction of aqueous outflow by alteration in cell size as well as cytoskeletal organization and extracellular matrix degradation or deposition. In normal subject, there is certain enzymes that is responsible for the catabolism and the angle. Steroid inhibit these enzymes. So the accumulation of glucopolysaccharides and other things in the angle because of the inhibition of the active material or active agent that take care of agents that take care of these materials. So inhibition of these enzymes lead to accumulation, and so these things together. In addition, this is occurring in normal subject. So what about if it is occurred in already altered trabecular meshwork, insulted trabecular meshwork? The effect will be much more, definitely. So this is very important. And I don't want to go very deep, so because we need to cover it as much as possible. Open angle uveitic glaucoma, so it is a microscopic change. You see, that's you can see the inflammatory cells and these things, but again, the mechanical due to mechanical blockage of the pathway by proteins and inflammatory cells, chronic inflammation due to the inflammatory cells and cytokines, as well as trabeculitis involvement, direct involvement of the trabecular meshwork, and steroid induced, of course. And then we have the other form of trabecular meshwork, which is the glaucoma, I mean, the angular glaucoma due to morphological changes, as we saw that in that picture. So this is very clear due to this is a Sudanese guy. When I was second year resident, he had ankylosing spondylitis, HLA-B27 positive, uveitis, and he came with a huge Bombay, Iris Bombay. So higher you'll be, and so on. And so the first thing we had to do is to reconstruct or to reform the anterior segment. We did laser BIs, multiple laser BIs, deflated the balloon or the iris Bombay. Then they remained with a broad anterior synetia and elevated intraocular pressure after controlling the intraocular inflammation. So we dealt with that in the appropriate way. So yes, this is the difference. So this is microscopic changes, and this is macroscopic morphological changes. So how do we manage glaucoma? Any question in the mechanism? Yes, please. Any question? Okay. So the mechanism evaluation. The most important thing is to evaluate condition. You are in the clinical emergency room, and then you are patient with uveitis and Uveitic glaucoma. So evaluation by taking a good history and listening to his symptoms, and then doing your or looking for your sign, doing your proper examination. So examination, it depends on the to look for the visual function affection, how much it's affected through the telemetry, slit lamp examination, looking for something that can help you in finding the etiology or even the mechanism of pressure elevation, clues. And also, when you go to the gonioscopy, it's a mandatory, like the scope of a cardiologist. Otherwise, he will not reach anything. This is very important in the classification of the mechanism of pressure elevation. So this is extremely important. And then the fundus, to look also for clues that might take you to the diagnosis of the uveitis, as well as to evaluate or to see how much damage from glaucoma point of view. From a glaucoma point of view, is the disc is severely affected. So when you plan your treatment, depends on the situation of the glaucoma stage, disc status, nerve fiber layer status, and so on. These are very important in diagnosing the underlying pathology on top of uveitis, the stage of the glaucoma stage, as well as the mechanism by which the uveitis induce the glaucoma. They are extremely important. Of course, UVM nowadays are available in all tertiary centers and so on. So you look to the corneal angle and ciliary body. Sometimes, of course, when you see it's a chronic disease, you will see that the ciliary body process has been affected. And so it's just very important in helping you reaching the diagnosis and the mechanism of the disease and mechanism of glaucoma. So this will take you to a proper diagnosis of both conditions. This is without this, you will get lost. Okay. So what is the management? Very important conception. If you didn't get anything from this lecture except this is enough for me. So under treating, we saw the steroids and their effect on the elevation of the pressure. So under treating the uveitis with corticosteroid to minimize their effect on IOP and intraocular pressure elevation is at the expense or on the expense of controlling the inflammation. So you are trying, يعني توازن الامور. I will not give مثلا Q1 hour or topical steroids or subtenon or whatever because of the risk of elevation, further elevation of the intraocular pressure. This is, they call it false economy. خسران خسران. This is false economy. So you are not going to lose the eye because of the pressure, but you will lose from the underlying pathology. It will destroy the eye. It will destroy the visual function. So you need to be stepwise. What is the prerequisite? What is the priority? The priority, whatever the level of the pressure is, you need to treat the underlying pathology with steroids, if it is steroid is the right drug to treat, as frequent as possible in the way that you think systemic, subconj, subtenon, topical. You have to control the inflammation. Then deal with the effect of the inflammation and the therapy of inflammation, which is the steroid. Without this, you will reach nothing, because elevation of the pressure you can't control whether medically or surgically, or there are solutions for the high pressure. So, but need first to control the disease, the underlying disease. So, of course, this is the I need to give time for discussion. So, medical treatment is the glaucoma medication. What is important here is that the myotics, it is the eye is inflamed, angry, and so on. The blood aqueous spiral is broken, so you are giving myotics will increase the risk of development of the posterior cyanic. So it's not appropriate treatment and to reduce the pressure at all. Actually, I should say an active disease should be contraindicated. Yeah. So what is the surgery? It's okay. We control the underlying pathology, the uveitis, and we gave medication. Some patients responded and well, but percentage, as we saw in our patient with uveitis, developing secondary glaucoma, 50% almost of them, they need surgical intervention. In other studies, probably more than that. It differ on the type of the disease or the pathology or so, and the rate of the or the prevalence of the disease in these patients depends on their presentation and their severity, chronicity, and so on. So you treated the underlying pathology, controlled the inflammation, and the medication given, and some of them they responded. What about those who are needing further or more than the surgical than the medical treatment? There are, surgical options, laser iridotomy, of course, or iridectomy, surgical iridectomy, as you saw in that Iris Bombay. You need to deflate it's a must, deflate whether laser or surgical to deflate this Iris Bombay. So if there is a pupillary block, it's a must, whether with laser or surgical. Trabeculoplasty, unfortunately, there are studies that has been reported. It's not effective at all. I believe it's like when you treat when you consider cyclophotocoagulation, as we'll see later, to the ciliary body, you are also injuring the trabecular meshwork, which is already damaged. So it's not effective. Maybe have early response for some time due to many things, but it's not the ideal or it's not the appropriate treatment, at least in the school that following. Trabeculectomy with antimetabolites, benign-penetrating hysterectomy that's invented by us and others in Europe, more before us and so on, tube surgery and goniotomy, cyclophotocoagulation. For trabeculectomy, this is a very successful procedure where you cannot, sometimes you cannot do other procedures. You need to do trabeculectomy, good conjunctiva, everything. Well, so the outcome is good if you took all the precautions that to control inflammation. And by the way, you will see in the textbook you have to have controlling inflammation 3 months later. You have to intervene surgically, or you cannot intervene before 3 months. We don't see this is an essential thing. Once it is controlled, you can intervene. So success rate is variable, changing with time also. But as you know, trabeculectomy is associated with a lot of normal glaucoma and ordinary glaucoma associated with complication like inflammation, hypotony, cataract progression or induction. These are very well-known complications of filtration surgery in general. In this disease also, these complications probably have a more chance to develop. And these are because you are dealing with a sick eye, not only by glaucoma only, but also by another disease. So expected to have these complications. So the less you intervene or the less you touch the eye, the better the outcome. So, and when we look to in Japanese, I think this is a Japanese, yeah, study. They look to the outcome of trabeculectomy with mitomycin C in primary open glaucoma and compared to similar number, about 100 cases, to patient with Uveitic glaucoma, and they found that eyes with was less effective in eyes with uveitic glaucoma compared to the eyes with primary ordinary open angle glaucoma. Not only that, but also they found that this is what we mentioned earlier about the complication. They said that the higher patients after trabeculectomy and uveitic glaucoma developed cataract needed intervention. 60% to 10% in patients with primary glaucoma. So yes, this is very important study, and you can, if you go and read this article, those who are interested in uveitic glaucoma, it is very helpful and very good. Tube surgery, uveitic glaucoma, of course, tube surgery, it is a successful if there is no other option better than tube surgery. It has a variable success and decreases with time. But this is probably you cannot judge it because, as we mentioned, are we following the protocol to control the underlying pathology and then to use whatever procedure, tube, trap, deep hysterectomy also. So Yes, and in addition to the complication that usually associated with filtration surgery in general, there are a certain complication related specific for this tube, which is the corneal decompensation, as well as occlusion of the, I think, occlusion of the tube and exposure of the tube and all, bacularity, complication bacular to the tube itself. So, uh, yeah, and again, this is a very nice study in American study, I think. So 80 patient children, 80 children with uveitis, 30 of them needed tube surgery and underwent tube surgery. The other 50, they took them as a control. And after some time, or 3 years, mean follow-up 3 years, they found a significant number drop in the endothelial cell count in patient underwent tube surgery. Yes, we know that tube surgery has usually associated with, not usually, always associated with decrease in the endothelial cell count, but depends on many things, location, size, blah, blah, blah. So I've stated for the cornea before. So this is in children. So after me follow-up 3 years or 5 years, they found significant. So these patients or these children are expected to live for long. So they are most likely will end it with corneal decompensation later on. So it's not the ideal procedure in children, but sometimes you have no other option. Okay, so you can go ahead and use it. So of course, يعني, I'm not from the people that believe in such intervention. Cyclophotocoagulation that has short success rate and has a lot of complication. I don't use or utilize this procedure as others, many others worldwide. You are treating the target of the disease, that who was ciliary body problem. There is cyclitis there in this patient. So you treat them with laser. It is, I'm not sure. Okay, if the eye is already, all the conventional therapy, surgical intervention also has been exhausted, no problem with that. But to give it as an early, and I have seen cases in our country being subjected to cyclophotocoagulation as a first procedure. In my the story in Samir or whatever, I would say this is a malpractice. Maybe others they disagree with me, but cyclophotocoagulation as a primary procedure in such patient, and I disagree with that totally. So anyhow, it's not an effective and not an appropriate treatment except in late resort. So I will share with you in 5 minutes. I will not go deep in the study, but I will share you a very beautiful prospective study that we did it in our hospital in King Abdulaziz University Hospital with my colleagues in the Viatis division, and we looked and we have shared our experience in the literature also. But this study is about 33 eyes of 21 patient, and I will not go deep in these things. So I will show you. It's okay. Many of them are VKH or Banyobiat or Boctonaga disease, and the pre-op intraocular pressure was 37, and the number of medication quickly is about where is it? Lens status, previous surgeries, number of medication about 3.2, and all these patients underwent pre-operative preparation. As I told you, must eyes be quiet, otherwise don't intervene. You are wasting your time, as I said in the last week in neovascular glaucoma. You have to have a well control of the intraocular inflammation, otherwise no need to intervene by any mean or any surgical intervention. Nothing will help. So well-controlled inflammation, as I said, it's not necessary to be 3 months. And of course, these things you will find in the handout and so on. So what is the technique is the same as we're doing in normal open angle glaucoma. So uh, the yeah, okay. So this is a short video to show you the beauty of this procedure. You are not entering that. It's an extraocular procedure. It will probably a few seconds. So, what do I have that? Anyhow, so this is what you do. You create the flap, the superficial flap, as a trabeculectomy, regular, but larger, a little bit, 555. So they told that it's working, but it's not working. It's not a problem. But it is very nice to show you the beauty of this procedure. It's tackling the area of pressure elevation. ايوه لو سمحت قلت لي انه اشتغل وقعدت قلت له شغال طيب هو دايما كده. Anyhow, so we create the superficial flap, but we increase it a little bit in 5 by 5. Then we use the metamycin C, whatever you want to use, 2 minutes or so, concentration and so on. And then we start to create the second flap. We leaving the shoulders from here and one side. Yes, thank you very much. So, thank you. So we create the superficial flap. Then we go and clean, or we wash these with C, and then we create the second flap, leaving a borders of shoulders from here and here. I can see, as you are pointing here to the choroid, that you need very deep. You leave only 50 to 70 micron covering the uvea. لأنه this is the main source of our when we come to the roots of filtration. So now we de-roofed the trabecular meshwork. At this level, you can go and de-roof the trabecular. So now you see the oozing of aqueous. The eye is not penetrated. The chamber is deep. And then I'm taking the floor of the trabecular meshwork. It's very beautiful procedure. This is my procedure in open angle of choice, in open angle glaucoma and open angle uveitic glaucoma. It is very, next day you come relaxed. You are not under tension what you're gonna to see. So, and then you can, of course, you can increase the window and cut the deep flap and suture the superficial flap. You don't need even to tight suture and see khalas. There's a barrier, natural barrier, as you'll see later on. And yeah, so everything. So what are the results here? There is also complete success. And one point here, the complication. Where is it? There's no much difference or no difference. Complicate or no. Actually, the complication is much less than what we see in ordinary or similar, or of course much less than in trabecular meshwork and trabeculectomy. As you see, the pressure was after mean follow-up almost a minimum of 1 year and up to 10 years. The IUB mean follow-up is almost 4 years. So the mean follow-up came from 37 to 14, and the number of medication came from 3 point something to 0.4. This is a very good success. And when you look to the success rate, you will find that the overall success rate, it's okay. But overall success rate is 94 after this long average or mean follow-up. This is usually don't see it in our normal patient with open angle glaucoma. Why? Because these patients usually, as I told you last week, these patients usually under better care from us and from the uveitic group division. Always they are under frequent visits, and if there is anything wrong that you can intervene. So the outcome is really extremely important. It's very encouraging. So yeah, it's okay. No much devastating complication. And when we look to what has been, yeah, this is the complication. There's no probably cataract, and we know that these patients under heavy steroid after surgery and before surgery. And when we look, yes, this is very important. When we look to what has been published in the literature, we have here, it's very important, the overall success rate here. Different eyes, different hands, different type of population and so on. But you look that it is comparable. The overall success rate is comparable for all these studies. Depends on the also different the follow-ups and so on, and the follow-up duration and so on. So yeah, and the interesting thing in this studies, there is no visually devastating complication as we usually see it after tube or after trabeculectomy, because I believe all of them they went through a strategic planning how to deal with these patients, controlling the inflammation, making sure that it's controlled. Then you do the appropriate procedure. So this is very important. So this is the root of that. I will not discuss it, but one of our patients, this one, we see it after many years. And a root of filtration, I will stop just with the conclusion, just to see if there, of course, there's nothing called long-term care. It is I did it anyhow. So we need to summarize that glaucoma, yes, is a common or relatively common complication until it's complication of the uveitis. But this is the message from me, at least not to forget it, that glaucoma should not be an obstacle or elevation of the pressure, whatever the level, shouldn't be an obstacle for aggressive treatment of intraocular inflammation. This is the message of this lecture. If you remember this only as under training now, this is the most important point in this whole lecture. So, and again, yes, controlling inflammation is a prerequisite that I told you for the success of any procedure you're going to do. So without controlling the inflammation, you are losing or it's a lost battle. So again, and we found that, as others found also, that deep hysterectomy is ineffective with high safety profile in open angle uveitic glaucoma, not closed angle. So with this slide or with this, that I will stop here and see if there is any question or so. Thank you very much.